This conference will now be recorded.
Students, can you see the screen? Can you see the slides? Can you hear me?
Yes, sir.
Okay, good. Right. So today we're going to continue with thalassemia. We discussed about thalassemia in the last class. We spoke about the inheritance of thalassemia, the types of thalassemia, the clinical features of thalassemia, and a little about the pathophysiology behind the clinical features of thalassemia. We also discussed about few of the complications that can occur because of iron overload in thalassemia. Right. So just reviewing back the previous slides. So these are the complications. There are transfusion-related infections, transfusional iron overload, toxicities of iron chelation therapy, and bacterial infections. The types of complications are cardiac, liver, endocrine, and bone complications. Cardiac complications, if the ferritin is greater than 2500, then you can see it in MRI T2, and cardiac dysfunction can be there, and arrhythmias are the most common complication seen in iron overload. Chelation therapy is the treatment for it. There's liver complication that includes transfusion related viral hepatitis and other liver pathologies, but can be diagnosed using elevated liver enzymes and the liver iron concentration. So endocrine complications are because of thyroid, parathyroid, pituitary gland, gonad, and pancreas. So thyroid can cause hypothyroidism, parathyroid can cause hypoparathyroidism, pituitary gland damage can cause short stature and even gonad in development and hypogonadism. And when the gonads are affected, there's delayed puberty, hypogonadotropic hypogonadism, and because of pancreatic damage, they can have impaired glucose tolerance, eventually leading to diabetes. Bone complications are because of overgrowth of the bone marrow hyperplasia. And the last one is spleen, hypersplenism, which requires splenectomy because of elevated destruction of RBCs. And so, yeah, the causes of death are congestive heart failure, arrhythmia, sepsis secondary to increased susceptibility to infection post-splenectomy, multi-organ failure due to hemochromatosis. This is how a child with thalassemia major might look like. Chipmunk faces, frontal bossing, depressed nasal bridge, and giving a mongoloid appearance. So, so coming to diagnostic evaluation, how do you diagnose and how do you evaluate a case of thalassemia? So first, if you suspect thalassemia because of physical features and age and presentation of the patient, you will go for a complete blood count with red cell indices and peripheral blood film examination and reticulocyte count. Now, in complete blood count, the HB will be low. The total RBC count and hematocrit will be decreased. Thalassemics have uniform microcytosis without increase in red cell distribution width. Now, red cell distribution width is increased in which disorder is my question. Can anyone answer this in the chat box? Red cell distribution width is increased in which type of hematological disorder? Can anyone type in the answer in the chat box? Macrocytic anemia, IDA, iron deficiency anemia. Any more answers? Sickle cell anemia, iron deficiency anemia, iron deficiency anemia, iron deficiency. So you guys are right. Whoever said iron deficiency anemia. So thalassemia and iron deficiency anemia both present with a microcytic hypochromic picture. Here below you can see the peripheral smear of a thalassemia child will have a characteristic bizarre pattern of red cells which are microcytic hypochromic with poikilocytosis, polychromasia, Moderate basophilic stippling and fragmented erythrocytes target cells and large number of normoblasts. Now, the peripheral smear of an iron deficiency child will have the same except for fragmented erythrocytes, but the red cell distribution width is high in iron deficiency anemia because the microcytosis is not uniform over there. There are going to be a larger amount of cells and also really small cells. So that is the red cell distribution width, the difference between the size of the smallest RBC and the largest RBC. So red cell distribution width is greater than 14 in iron deficiency anemia, whereas in thalassemics it's not increased. So that is the importance of RDW, red cell distribution width. You look at this table here. There's a small comparison between thalassemia trait and iron deficiency anemia. The red cell distribution width is normal. It's 11.5 to 14.5 in thalassemia trait. In iron deficiency, it's high. The RBC count, remember the RBC count is low in thalassemia trait, but it is high relative to the hematocrit and HB levels. So it is higher relative to the hematocrit and HB levels, whereas in iron deficiency anemia, it is low. So RBC count is still low when you measure it in thalassemia trait in the presence of anemia. So coming in thalassemia major and serum iron levels are increased, serum ferritin levels are high, TIBC will be decreased and transferrin saturation will be increased. Whereas in iron deficiency, obviously the serum iron will be low. Obviously the serum ferritin also will be low. The TIBC will be increased, the total iron binding capacity increases in iron deficiency anemia, and the transferrin saturation will be decreased. The transferrin saturation will be decreased because the affinity of apotransferrin receptors will be decreased. That's why the transferrin saturation is decreased. The next one is baseline serum ferritin and liver enzymes, including ALT, AST, bilirubin, lactate dehydrogenase. They should be measured. Now, in the presence of liver complications because of iron overload or either because of thalassemia, there's going to be hepatomegaly and increase in indirect bilirubin because you're going to have hemolysis here. So unconjugated or indirect bilirubin will be increased, and there will be excretion of this in the urine and also in the fecal matter. AST, ALT will not usually be increased unless there is an associated hepatitis. Could be viral or toxic or iron-related hemochromatosis or whatever. And LDH, lactate dehydrogenase, which is usually highly present in the RBC membranes because of hemolysis, it will be increased. So LDH will also be increased. So serum ferritin will be increased. Liver enzymes, ALT, AST might be increased. Bilirubin in the form of indirect bilirubin will be increased, and lactate dehydrogenase will be increased. Full red cell phenotype. All these are phenotypes of red cells. Phenotyping other than normal blood groups and RH phenotyping. This is also done in case of thalassemia. Full red cell phenotyping will be done. The next one is serological testing for hepatitis A, B, C, and HIV should be performed as baseline measures. So you don't want associated hepatitis because it is a much higher mortality in the presence of thalassemia because of the anemia and also because of the existing congestive cardiac failure because of severe anemia. The patients who develop this viral hepatitis or HIV can have a poorer prognosis than normal people without thalassemia. The next one is all first degree family members. That means the brothers, the sisters, or parents, they all should undergo HLA typing if potential future allogenic hematopoietic stem cell transplant is considered an option. So the definitive treatment for thalassemia is stem cell transplant, right? So you need to do HLA typing for all the potential first degree family members that can get a family transplant, a stem cell transplant for the patient. So next one is hemoglobin patterns in hemoglobin disorders. The beta thalassemia trait has the highest percentage of hemoglobin A, which is normal one. The normal hemoglobin contains 97% of hemoglobin A, fetal hemoglobin of less than 1%, and A2 of 2 to 3%. A2 contains what chains? Alpha and gamma chains, right? So beta thalassemia trait contains 80 to 95% of A, 1 to 5% of fetal hemoglobin, and 3 to 7% of A2. whereas intermediate contains 30 to 50%, 50 to 70% of fetal hemoglobin, and 0 to 5% of A2. Beta thalassemia major, which is most severe condition, contains 0 to 20% of A and 80 to 100% of F, fetal hemoglobin, and 0 to 13% of A2. HPFH, black heterozyte, contains 60 to 85% of A, 15 to 35% of fetal hemoglobin, and 1 to 3%. Black homozygote contains 100%. In alpha thalassemia trait, they'll have 85 to 95% of A, and that is the only hemoglobin that is present over there. In HBH disease, there'll be 60 to 94% of A, and in HB Barrett's hydrops, completely absent, so there'll be death in fetal. Osmotic fragility test will be decreased, and urinary urinobilinogen will be increased. That's also called Ehrlich test. Stool examination has dark stools, increased stercobilinogen. Radiological changes are seen after 1 year of life. Radiological changes are seen after 1 year of life. And X-ray of metacarpals, ribs, vertebra, they show thinning of the cortex. And X-ray of the skull shows hair on end appearance. Generalized skeletal osteoporosis also can be seen. Now, we discussed about sickle cell anemia in the previous class. Even that can have hair on end appearance. Which other hematological disorder will contain hair on end appearance? Which other hematological disorder will contain hair on end appearance? It's obviously seen in thalassemia and sickle cell anemia. Can anyone type in the chat box the answer? It can be seen in iron deficiency anemia, it can be seen in thalassemia, it can be seen in sickle cell anemia. One more common hematological disorder that also exhibits hair on end appearance. Answer, anyone? You can try, you can still be wrong. There's nothing wrong in being wrong. Leukemia. Excessive bone marrow hyperplasia. So giving out the pathophysiology behind the hair on end appearance. Very clever. But what disorder? Can you name any other disorder? Obviously, excessive bone marrow hyperplasia is seen in all hemolytic anemias. So that gives a clue. Which other common hemolytic anemia can you see hair on end appearance other than the ones we've already discussed before? G6PD deficiency. Yes, it can be seen in G6PD. Anything else? A relatively more common hematological disorder. An RBC membrane defect like thalassemia. Sickle cell anemia, I've already said sickle cell anemia, Satish. Sickle cell anemia, you can see hair on end appearance. Very good, Anisha. Everyone, yeah. Hereditary spherocytosis, that's the answer. So hair on end appearance is most commonly seen in these 4 conditions: sickle cell anemia, thalassemia, hereditary spherocytosis, iron deficiency anemia. Can also be seen in J6PD deficiency, but less likely over there. So next, as generalized skeletal osteoporosis can be seen because of bone marrow hyperplasia. So how do you manage a case of thalassemia major? Now, thalassemia trait is no big deal. You can easily manage it either by iron, uh, sorry, either by blood transfusion if the patient has much lower anemia, or you can just give supportive therapy for these patients with thalassemia trait. And depending on the severity of anemia, the treatment varies for them. But for thalassemia major, you know that the patient is going to have severe anemia. You know the patient requires blood transfusions because the anemia is so severe that it can produce congestive cardiac failure also. And eventually, because of repeated transfusions, these patients will also have iron overload. So the first step is how do you correct the anemia? The second one is how do you correct the excess iron overload? The third thing is how do you manage the complications? The same is given in this slide. Comprehensive management includes the following. First one is confirmation of the diagnosis. We have confirmed that in the previous slides. The next one is correction of anemia, packed red cell transfusions. The next one is removal of excess iron in the form of chelation therapy, management of complications through endocrine and cardiac complications, pharmacological methods to increase gamma chain synthesis. So increasing the production of fetal hemoglobin, HbF, supportive care and curative treatment, which is stem cell transplantation. Future treatment that is being researched right now is gene replacement therapy. So first one is transfusion therapy in thalassemia. It has two goals. One is to prevent anemia. The second one is to suppress endogenous erythropoiesis. So regular blood transfusions are presently the mainstay of treatment of thalassemia major. The concept of neocyte transfusion is being done. Protocols are palliative. Pre-transfusion, HB level is around less than 7 and mean hemoglobin is maintained is less than 8.5. That is palliative therapy. And hypertransfusion is pre-transfusion HB level is around greater than 10 and mean HB level maintained is greater than 12. So from above 10 to above 12. Super transfusion is from above 12 to above 14. Moderate transfusion is around 9 to 10.5 and mean hemoglobin maintained is greater than 12. So moderate transfusion is probably the current recommendation because it's the easier one to maintain. The palliative one is only done as palliative treatment, but the consensus is to maintain a moderate level of hemoglobin, that is around 12. The type of transfusion is a leuko-reduced packed red cell transfusion for thalassemic children. The reduction of leukocytes to 50 lakhs or 5 million is considered adequate. It's reduced by 70% in one transfusion. It helps in prevention of transfusion reactions and is achieved by centrifugation, saline washing, or filtration. What are the methods for leukodepletion? Centrifugation of the packed red cell transfusions, saline cell washing through triple saline wash, deglycerolized red cells, third generation leukocyte filters, and irradiated blood cells. You just know these are the methods for leukodepletion. You don't have to know these in detail. That's why we're not going through this more. So what are the benefits of blood transfusion in thalassemia major? It improves tissue oxygenation and prevents chronic hypoxia. That is obvious. Improves normal growth and development because the utilization of body stores or nutrition is now being done for growth and development rather than for production of red blood cells. So bone marrow hypoplasia does not occur, but bone hypoplasia occurs, which leads to growth and development. The next one is prevents erythropoiesis, that avoiding the expansion of the bone marrow and extramedullary erythropoiesis. And it reduces hemolytic phases also because the excess production of RBCs is not necessarily done in the bone marrow now because of the transfusions. There is no hemolytic phases, no maxillary hypertrophy or zygomatic hypertrophy, there's no frontal bossing, there's no depressed nasal bridge, there's normal phases. Reduces hepatosplenomegaly and cardiomyopathy. If there's anemia, then patient is going to have cardiac overload and eventually will lead to dilated cardiomyopathy and hypertrophic states. Maybe a hyperdynamic circulation can occur because of anemia, and hepatosplenomegaly will also occur. That will be prevented or reduced because of blood transfusions, and it also reduces the gastrointestinal absorption of iron. Now, because the anemia is being corrected, the receptors in the gut which absorb iron will be decreased. So hepcidin will be increased and decreased absorption of iron will occur through the intestines. When to start the transfusion? Wait, let me ask you one small question and let's see how good you remember the previous classes. What is the uh, transporter molecule that is used to transport iron from the intestines into the blood? What is it called? Do any of you remember what it's called? Let's see if you can answer really fast. Very good. Ferroportin. That's the answer. First one. Shanti Deepika. Good job. Right. So, when to start the transfusion? Blood transfusion is started as soon as diagnosis is firmly established, except in children greater than 18 months of age. So if the diagnosis of thalassemia is done below 18 months of age, you need to start the transfusion to correct the anemia and to prevent any further excess hemopoiesis, any excess production of RBCs in the bone marrow. This will ensure that the growth of children between the ages of uh, 28 days to 18 months will be good, because there will be a growth spurt in the initial few months of life. If the age is greater than 18 months, these children are observed to rule out thalassemia intermedia, and if hemoglobin drops greater than less than 7, then you go for first regular transfusion uh, as the palliative treatment. Then eventually go for super and hyper transfusions also. And the most ideal way to transfuse thalassemics is using group and specific type saline washed packed red cells, uh, and that are compatible by direct antiglobulin test. So you have to go Coombs cross-matched blood. What are the rate and frequency of transfusions? This is very important because you need to ensure that the patient has a physiologically normal hemoglobin. That doesn't mean the patient needs to have 15 or 16 hemoglobin. At the early age, like when the children are toddlers, the hemoglobin will be much higher than adults. So it'll be up to 16, 17, can be 18 also. But in these thalassemics, you don't need to go up to that extent. You can maintain it about 12. So the frequency and the rate of transfusions is very important. So first is the recommended one is 10 15 ml per kg of saline washed packed red cells every 3 to 4 weeks. So an adult transfusion requires 350 ml. Usually we go for 1 pint of packed red cells. So that's 350 ml. But what if the patient is a really small child and he weighs around 5 kgs? So you can't give 350 ml of packed RBCs here because there'll be cardiac overload for that particular patient. So here you need to go for around 10 ml per kg. So if the patient is around 5 kg, you just have to give 50 ml or maybe up to 75 ml. That's it. So the amount of blood required in the initial ages of life is much less compared to the blood required that is in the much later ages of life, where the weight increases and the requirement of RBCs also increase. So that's why the rate not more than 5 ml per kg per hour is being transfused. However, in patients with cardiac dysfunction, not more than 2 to 3 ml per kg per hour should be given. So 2 to 3 ml per kg per hour means in a 5 kg person or a 5 kg child, I mean, you're going to have around 10 ml per hour. That's it. 10 to 15 ml per hour is the maximum that you should be given in the presence of cardiac dysfunction. If it is around 5 ml per kg per hour, you can give up to 25 ml per kg per hour. So 25 ml per hour. The next one is shorter intervals of 2 to 3 weeks are more physiological. So you have to transfuse up to 3 weeks, and after that, the patient might develop anemia. Average time taken for transfusion is 3 to 4 hours. Approximately 180 ml per kg of red cells are required to be transfused per year in non-splenectomized, non-sensitized patients to maintain the hemoglobin about 10 grams, whereas splenectomized patients require 133 ml per kg per year. Because the absence of spleen will have less hemolysis, the requirement of blood transfusion is also less. Even without hypersplenism, the requirement is 30% higher in non-splenectomized patients. So you eventually go for splenectomy, and then the transfusion rate will also decrease. the requirement will also decrease. The complications of transfusion are just like any other transfusion: non-hemolytic febrile transfusion reaction, allergic reactions, acute hemolytic reactions, delayed hemorrhagic reactions, transfusion-related acute lung injury, transfusion-associated circulatory overload, alloimmunization, transfusion-transmitted infections, and iron overload. Steps to prevent these infections include screening of blood products. All thalassaemic children should receive hepatitis vaccination if not previously immunized. Leukodepletion can minimize CMV infection. Excuse me. So the next part is iron overload and chelation therapy. Iron overload occurs in thalassaemic patients due to treatment with multiple transfusions, ineffective erythropoiesis, excessive dietary absorption of iron from gut to compensate the large turnover of red cell mass, lack of physiological excretory mechanism for excess iron. That is the main reason there is iron overload. There is no excretory mechanism for excess iron except through reticuloendothelial cells and RBCs that are lost through the gut or the urine. That's it. This is the only excretory mechanism that is very, very low compared to the amount of iron that is present in the body. The goal of iron chelation is to reduce the iron stores and subsequently maintain the serum ferritin less than 1000. What is the indication for initiation of chelation therapy? Serum ferritin greater than 1000 nanograms per deciliter. The patient has received 15 to 20 transfusions. The hepatic iron concentration exceeds 3.2 mg per gram dry weight. So chelating agents are deferoxamine, deferipone, and deferasirox. These are the three chelating agents that we use. Deferoxamine is the most commonly used chelating agent. Its route is subcutaneous or IV. Dose is 25 to 50 mg per kg per day. Schedule is 8 to 10 hours over 5 to 6 nights a week with the help of subcutaneous deficerol infusion pump. Method of action is chelates loosely bound iron from the ferritin, hemosiderin, but not from transferrin. Excretion is through urine, 80%, urine becomes red, and also sometimes the feces. Plasma clearance of T-half is 20 minutes. Adverse effects include local skin reaction, ototoxicity, infections, ophthalmic toxicity, skeletal impairment. Monitoring long bone films in growing children, annual eye and ear checkup is the monitoring that is required for deferoxamine. When you require aggressive chelation therapy, severe iron overload where the persistently high ferritin value, liver iron greater than 15 mg per gram dry weight. Normally you go for chelation 3.2 mg per gram dry weight. Where it is 15, it's much more significant. If there's a significant cardiac disease like cardiac arrhythmias, evidence of falling ventricular function, evidence of very severe heart iron loading in MRI T2 aided image, prior to bone marrow transplantation, when rapid reversal of iron loading may be desirable. TAB vitamin C 1 hour is given 1 hour prior to transfusion. The next one is deferipone. It mobilizes iron from transferrin also, ferritin and hemosiderin. The dose is 75 to 50 mg per kg body weight per day in 3 to 4 divided doses. Excretion is through the urine. The plasma T-half is 53 to 166 minutes. Adverse effects are agranulocytosis, GIT disturbances, transaminase elevation, arthralgias. The monitoring is weekly CBC to look for agranulocytosis. The drug should be discontinued whenever the total WBC count drops to less than 3000 or the absolute neutrophil drops to less than 1000. Zinc deficiency may develop, so zinc supplementation may be necessary in this particular case. It may be the first line drug for patients which are not receiving DFO because of high cost, toxicity or poor compliance of the later. So in cases where you cannot give deferoxamine, that is DFO, you can give deferipone. Deferasirox is a novel chelating agent, belongs to tridentate thiazole with high affinity to iron as Fe3+ and chelates at a ratio of 2:1. And the dose is 20 to 30 mg per kg per day. Schedule is daily, once a day. Excretion is through feces. Plasma T-half is 1 to 16 hours. It should be given approximately same time each day on an empty stomach, 30 minutes prior to food. The tablet should be dispersed in water or orange or apple juice. It is available as 250 to 250 by 500 or 500 mg tablet for oral suspension dispersible tablets. It requires monthly RFT, LFT, and urine analysis. The side effects are GI disturbances, rash, or renal dysfunction. So defersirox is a novel chelating agent and is given orally. Manipulation of HbF switching to increase the production of gamma chains and the production of fetal hemoglobin. Hydroxyurea is used. It is also used in sickle cell anemia in cases of excess sickle cell crisis attacks in a year. Histone deacetylase inhibitors, butyric acid analogs. 5-azacitidine is not used anymore because of risk of cancer. Erythropoietin has been tried to induce HbF production with varying success. Now, the manipulation of HbF switching is much more useful in sickle cell anemia, whereas in thalassemia, it's not that evidently useful. The definitive treatment for thalassemia is stem cell transplantation. It is the only curative therapy available today. The source of blood cells, stem cells can be bone marrow, peripheral blood, cord blood, fetal liver. Though expensive, it is cost effective as compared to yearly cost of regular blood transfusion and chelation therapy. So the cost is 8 to 10 lakhs, but it actually takes around 20 lakhs. Umbilical cord stem cells have good results, lower graft versus host disease, and longer engraftment will be seen. Gene therapy in the form of lentiviral vector derived from HIV, where a large fragment of human beta gene and its locus control region have been introduced through experimental, more effective therapies will become available in the near future to cure the disease. So this is something that we've been working on, gene therapy. Not we, but scientists have been working on. And it's not been completely used, but it's experimental, and there's a little hope that gene therapy will be useful in thalassemia. So we've discussed everything about thalassemia. We've discussed about how to diagnose, how to treat thalassemia. So how do you do something prophylactically, like prevention wise? You go for thalassemia screening, carrier screening. So thalassemia minor or carrier state can be easily detected in a person by doing a simple blood test HbA2 by hemoglobin electrophoresis or a variant machine or column chromatography. And if the HbA2 is elevated, that means there is a carrier state. The prevention includes population education, mass screening, genetic counseling, and antenatal diagnosis and therapeutic abortion of affected pregnancy. Now, it is very difficult for a child of thalassemia major to lead a normal life. They require continuous blood transfusions through their entire life. Even the lifespan is reduced. There'll be complications of iron overload, and eventually they might require a stem cell transplantation. And the cost and the morbidity associated with this is very high. So that is why if a diagnosis of thalassemia is major is made antenatally, so that is one of the indication for therapeutic abortion of affected pregnancy, except in case of precious pregnancies where that is the only chance of pregnancy, right? So the carrier detection, the only confirmatory test is HbA2 estimation. They conduct an effective mass screening program. The target population should belong to the premarital and newly married groups, that is before they have begun their families. Now, antenatal diagnosis: when both partners who are thalassemia minors plan to have their baby, they are told to report to their hematologist as soon as possible after pregnancy is confirmed. Chorionic villus sampling is done between 9th and 11th week of pregnancy. Amniocentesis or chordiocentesis is 16 to 18 weeks of pregnancy. The test result: affected means the fetus has thalassemia major, or unaffected means the fetus is either thalassemia minor or normal. Affected fetuses are advised to be terminated and unaffected fetuses to be continued. That is the therapeutic abortion option that are given to the parents. So that is about antenatal diagnosis. So that is the end of thalassemia. We have discussed everything that is related to thalassemia in detail. Ideally, this should be a detailed discussion in pediatrics, but since we are covering hematology and we're discussing about hemolytic anemia, I went a little more in detail than that's given in Davidson or Harrison. So that's the end of today's class. If there's any doubts, you can ask me. So if there's no doubts, then we can stop this class.